Good afternoon to each one. Thanks to the organizing committee of Diabetes India, Dr. Bansi and the team. And we have heard very important three talks by Dr. Panikar, who is the teacher, now the teacher of the teachers, and other stalwarts like Dr. N.K. Singh and, of course, Dr. Virmani. Everyone has talked about sulfonylureas, pioglitazone, insulin, and the pre-diabetes, but none has put any pressure on a very important molecule, and that molecule is metformin. Dear friends, we cannot forget metformin, whatever level of diabetes management we reach to. And it is one of the oldest oral anti-diabetic agent, has become a medication with steadily increasing potential therapeutic indications. This presentation explores the pleiotropic activity and favorable effect of metformin in different pathological conditions, including pre-diabetes, even type 1 diabetes, gestational diabetes, and more, and we'll discuss about the right time to start. So what is the right time to start the metformin? You will come to know once I complete my presentation, and I'm thankful to my friend Dr. Alok Modi, who has helped me through the AI in preparing my presentation. When we go to the history of metformin, 1920s, it was synthesized from the galecin, a compound found in Galeja official list, that is the French millet. And that was the time immediately insulin was discovered. 1950, first clinical studies on metformin's glucose lowering effect in diabetes, and then from 70 to 90, it gains widespread use for type 2 diabetes treatment, and present time it is the first line therapy for type 2 diabetes and being studied for other indications also. What is the algorithm? Whatever the guidelines they say, whether it is ADA or ACE, it used to be with the lifestyle metformin, but the recent guidelines of the ADA, I don't know why they have not mentioned metformin, maybe because of some reason which we understand well. Its effect on the glucose metabolism, it reduces the hepatic glucose production, which is the most important, and inhibits gluconeogenesis and glycogenolysis. These two terms are very, very important. Peripheral glucose uptake is enhanced, insulin sensitivity is improved in muscles and the fat tissues. So not only pioglitazone, metformin also a very good insulin resistant, taking care of the insulin resistance. It decreases the intestinal glucose absorption, alters gut microbiome, and increases the GLP-1 secretion, and then it lowers the fasting insulin levels through reducing the hyperinsulinemia associated with insulin resistance. This is the pharmacogenetics through the transporters having a good clinical relevance, and the future directions, they say that the potential for personalized metformin dosing based on the genetic profile, which patient will respond to which dose of metformin, becomes very important here. And it is through the AMPK activation by the metformin, which inhibition of the mitochondrial complex 1, increased AMP ATP ratio, and the lysosomal effects and downstream effect of the AMPK activation we can see here. So, on the effect on the insulin sensitivity at the level of the muscles, increases the GLUT4 translocation to cell membrane, enhancing the glucose uptake, reduces lipolysis and improves insulin signaling, enhances insulin receptor expression and tyrosine kinase activity at the level of the liver, and there are systemic effects like reduction of the glucotoxicity and lipotoxicity, improving overall insulin sensitivity. It has an anti-inflammatory effect through the inhibit NF-kB signaling, and having a clinical marker like decreases the C-reactive protein. Nowadays, after the COVID, every patient wants for a C-reactive protein. CRP estimation, it lowers interleukin 6. So these are the markers, reduces the tumor necrosis factor alpha, TNF alpha, and again, the antioxidant properties of metformin reduces the oxidative stress, which is one of the pathogenetic mechanism of Complications of diabetes: it enhances the antioxidant defenses by increasing activity of antioxidant enzyme, protects the mitochondrial function, and it prevents the AGE formation. Now, the pleiotropic effect, which is again very important, the metabolic effect which lowers blood glucose, improves the insulin sensitivity, reduces body weight, and improves the lipid profile. Reduces risk of cardiovascular events. I am not quoting any trial here or any meta-analysis here, because we have to know what are the basics and what is the crux when it comes out of all the analysis of the RCT trials and everything. So through improving the endothelial function and lowering the blood pressure, the anti-inflammatory, antioxidant, potential anti-cancer. Now we'll come further how it affects that, and the neuroprotective. In pre-diabetes, as Dr. Urwan was telling, diabetes prevention program results, it reduced incidence of diabetes by 31% compared to placebo in high risk individuals. And the ADA recommends that consider metformin for preventing type 2 diabetes in those with pre-diabetes, especially for those with BMI above 35, those age less than 60 years, and women with prior gestational diabetes mellitus. So in type 2 diabetes, as the first line therapy, glucose lowering efficacy, weight control, cardiovascular benefits. And in type 1 diabetes, you must be feeling surprised that type 1 diabetes and metformin exempt to insulin therapy in a specific group of the patients. It improves glycemic control and reduces the insulin requirement, and there is weight management. So type 1 diabetic patients with overweight, to reduce the dose of insulin, this is another important drug. It can help weight loss with overweight, obese type 1 diabetics. And then, of course, there are cardiovascular benefits. The removal trials showed reduced atherosclerosis progression in these patients. In gestational diabetes, there is a controversy, and there is no consensus as of today. What DIPSI says something else. Some other organizers say something else. But I tell you one thing which is very, very important. In patients who are of PCOS and those who are on metformin, when the ovulation starts and conception takes place, please stop metformin, because it is a very important drug. During organogenesis of the fetus, it should not be used. This is very, very clear. So, first trimester of pregnancy, metformin should not be used, and those who are taking metformin, they should stop metformin. The lifestyle, then the medical nutrition therapy, exercise and everything, and if required, then give insulin. But after the first trimester, if required, you can again add metformin to these patients. Efficacy, as Dr. Panikar sir has also told, as efficacious as insulin, as efficacious as lifestyle. The reduction in HbA1c is in the tune of 1.5 to 2%. It is safe, generally considered safe during pregnancy, as I told you, where not to use, how to use it, and often preferred by the patient due to the oral use. In polycystic ovary syndrome, improves insulin sensitivity, it restores ovulation, reduces androgen levels, and the pregnancy outcome may reduce risk of gestational diabetes in women with PCOS. In non-alcoholic fatty liver disease, the potential benefits are reduces the hepatic fat accumulation. So if a combination of pioglitazone and metformin is used in such patients, the results are fantastic, wonderful. Improves insulin sensitivity, decreases the inflammation, and current status, it is yet not approved by FDA, not FDA approved for NFLD, but sometimes used off-label. Gut microbe alters the gut microbiota composition, enhances the short-chain fatty acid production, modulates bile acid metabolism, and potential mechanism of action is may be mediated through gut microbe changes. Nephroprotection, again, renoprotection effect are there, reduces the albuminuria, slows the decline in EGFR, and improves the tubular function. And current guidelines say that it can be used safely in patients with EGFR of more than 30 ml. Lipid metabolism, of course, reduces plasma triglyceride levels, modest reduction in LDL, slight increase in SDL. Through the it increases the fatty acid oxidation, reduces lipogenesis, and improves insulin sensitivity. Body weight neutral or modest loss. Mechanism of weight loss is through the it reduces the appetite, increases energy expenditure, and alters the gut microbiome. Beneficial for overweight, obese patients with type 2 diabetes, and of course, sustained weight loss observed in long term studies like DPP. Cardiovascular specters on the blood pressure, on the endothelial dysfunction, on platelet function, and through the fibrinolysis. Cardiovascular protection is, of course, there. It has been shown in the UKPDS results through the improved endothelial function, reduced inflammation, and improved lipid profile. Heart failure may be beneficial in diabetic patients with heart failure, contrary to the previous concerns. And secondary prevention reduces cardiovascular event in patients with established cardiovascular diseases. Heart failure historically contraindicated due to the lactic acidosis risk, but current evidence observational studies show reduced mortality and hospitalization in metformin users with heart failure. Kidney functions, of course, I told you previously contraindicated in renal impairment, but now it can be used up to an eGFR of more than 50. It reduces albuminuria, slows the eGFR, and improves tubular functions. Cancer prevention, which is again very, very important. The epidemiological event says that the reduced cancer incidence in metformin users and strongest evidence for colorectal, pancreatic, and the hepatocellular cancers. And I think the potential mechanism is through the inhibits mTOR pathway, reduces insulin, IGF-1 signaling, and activation of the AMPK. But ongoing research is required. Adjuvant cancer therapy, then neurodegenerative diseases like the Alzheimer's disease, Parkinson's disease, mechanism, and preclinical evidence promoting clinical trials are ongoing. Aging, lifespan extension, increased lifespan in animal models, delayed onset of age-related diseases in some studies, and the TAME trial ongoing study to assess the metformin's effect on the aging in human. Longevity again, very important. Animal studies increase lifespan in women and mice, but in human studies, observational data suggests reduced mortality in metformin users compared to the non-users. In special population, elderly, use with caution, monitor renal functions. Genetics, as I told you, FDA approved for type 2 diabetes in children 10 years and older. In pregnancy, category 1B, growing evidence for safety in gestational diabetes, as I have mentioned. Chronic kidney disease also. And metformin combination therapy, we have already heard from Dr. Panikar and Dr. Virmani. These are the various formulations. And when we talk of metformin versus the newer anti-diabetic agents, efficacy 1 to 1.5%, SGLT2 inhibitors 0.5 to 1%, and GLP-1 receptor agonist 0.8 to 1.5%. This is the decrease in the HbA1c. You can see the weight effect, the cardiovascular benefit, the renal benefit, and look at the cost. All these medicines, SGLT2 inhibitors, GLP-1 receptor agonists, they are very, very costly. Safety profile, of course, we have to look for the common side effect, and which is the most important and most troubling to our patients is the GI disturbances like the nausea, diarrhea, abdominal distension, abdominal discomfort, gas formation. Vitamin B deficiency, especially in vegetarian people. Then the lactic acidosis is very rare and it is contraindicated in severe renal impairment, acute or chronic metabolic acidosis. These are the future directions: cancer prevention and treatment, neurodegenerative diseases, the aging and longevity, and the novel formulations. So to conclude my talk, proven efficacy, pleiotropic effects, safety profile, cost effectiveness, and the future potentials. So now the question is before you: when should we start? What is the time to start metformin? I think after the lifestyle, and not after lifestyle. With the lifestyle management, we must start metformin, and then we should see, as Dr. Birmani said, hit hard, hit early to prevent the complications. So if any other agent to be added, depending on the patient profile, we must do that, but never forget metformin. So before I thank you all, I invite you all at Delhi for the seventh annual conference of Innovative Physician Forum, 5th and 6th July. And thank you very much. Thanks.